When placing a dual-lumen cannula, e.g., Avalon, via the right internal jugular vein, where should the distal tip ideally be positioned? A. Superior vena cava, SVC. B. Mid-right atrium. C. Inferior vena cava, IVC. D. Right ventricle. Answer: C. Inferior vena cava, IVC. Explanation: a dual-lumen cannula drains from both the SVC and IVC. To do this, the distal tip must sit in the IVC, while the proximal drainage port sits in the SVC. The return port must be precisely aligned in the right atrium facing the tricuspid valve. Which of the following is a contraindication to femoral arterial cannulation for VA ECMO? A. Severe peripheral arterial disease, PAD. B. History of appendectomy. C. Mild hypertension. D. Body mass index, BMI, of 25. Answer: A. Severe peripheral arterial disease, PAD. Explanation: severe PAD or aortoiliac disease can make it impossible to pass a large bore cannula and significantly increases the risk of limb ischemia or vessel rupture. During a VV-ECMO weaning trial, the sweep gas is off, but the patient's PaCO2 begins to rise rapidly above 60 mm of mercury despite optimized ventilator settings. What does this indicate? A. The patient is ready for decannulation. B. The patient has failed the weaning trial due to inadequate ventilation. C. The ECMO pump speed is too high. D. The oxygenator is clotted. Answer: B. The patient has failed the weaning trial due to inadequate ventilation. Explanation: if the patient cannot maintain a normal CO2 level through their own lungs, via the ventilator, when the sweep gas is off, they still require the ECMO for decarboxylation. What is the delta P in an ECMO circuit, and why is it monitored during weaning? A. The difference between systolic and diastolic pressure. B. The pressure gradient across the oxygenator, premembrane minus postmembrane. C. The difference between the patient's MAP and the pump pressure. D. The change in venous oxygen saturation. Answer: B. The pressure gradient across the oxygenator, premembrane minus postmembrane. Explanation: delta P monitors the resistance within the oxygenator. A rising delta P suggests clot formation inside the membrane, which can complicate the weaning process or necessitate a circuit change. In central VA ECMO cannulation, where is the arterial return cannula typically placed? A. Femoral artery. B. Ascending aorta. C. Axillary artery. D. Carotid artery. Answer: B. Ascending aorta. Explanation: central cannulation involves a sternotomy, where the drainage is from the right atrium and the return is directly into the ascending aorta. This provides superior flow and avoids north-south syndrome. What is the physiological goal of rest settings on the ventilator during the period between cannulation and weaning? A. To maximize recruitment with high pressures. B. To prevent ventilator-induced lung injury, VILI, by using low tidal volumes and pressures. C. To provide 100% of the patient's oxygenation. D. To hyperventilate the patient to assist the ECMO. Answer: B. To prevent ventilator-induced lung injury, VILI, by using low tidal volumes and pressures. Explanation: ECMO allows the lungs to rest. By using low volumes, less than 4 milliliters per kilogram, and low pressures, we prevent further damage, allowing the lung tissue to heal before weaning is attempted. Which bedside test is most critical to monitor immediately after decannulation of a femoral arterial line? A. Serum creatinine. B. Distal pulse checks and neurovascular assessment of the leg. C. Liver function tests. D. White blood cell count. Answer: B. Distal pulse checks and neurovascular assessment of the leg. Explanation: decannulation carries risks of hematoma, retroperitoneal bleed, or arterial thrombosis. Frequent checks of the DP, dorsalis pedis, and PT, posterior tibial pulses are mandatory. During VA ECMO weaning, why is it important to monitor the left ventricular, LV, distension? A. Distension can lead to pulmonary edema and stasis-induced LV thrombus. B. It indicates that the heart is too strong for the pump. C. It is a sign of dehydration. D. It means the drainage cannula is malpositioned. Answer: A. Distension can lead to pulmonary edema and stasis-induced LV thrombus. Explanation: if the LV cannot pump against the retrograde flow of the ECMO, it becomes distended. This increases wall stress, prevents recovery, and causes blood to back up into the lungs. In peripheral ECMO, if the patient develops Harlequin syndrome, what is a potential cannulation-based solution? A. Increasing the RPM of the femoral pump. B. Converting to veno-arterial (VVA) ECMO. C. Removing the distal perfusion catheter. D. Switching to VV-ECMO immediately. Answer: B. Converting to veno-arterial (VVA) ECMO. Explanation: adding a venous return cannula (VVA) delivers oxygenated blood to the SVC/right atrium, ensuring the heart pumps oxygenated blood to the brain and upper body. What is the standard anticoagulation target, ACT, usually maintained during the weaning phase, assuming no active bleeding? A. 100 to 120 seconds. B. 180 to 220 seconds. C. 300 to 400 seconds. D. Anticoagulation is stopped 24 hours before weaning. Answer: B. 180 to 220 seconds. Explanation: while targets vary by center, an ACT of 180 to 220 seconds, or a specific heparin PTT/anti-XA range, is typical to prevent circuit thrombosis, especially as flows are lowered during weaning trials.